So good morning, everybody. Good morning. That's automatic. We're glad that you all joined us this morning. I'm Helen Jones-Kelly. I'm the Executive Director at the Alcohol, Drug Addiction, and Mental Health Services System for Montgomery County. And I'm really thrilled to have you all joining us because we know that the topic we're going to share some time talking about today is probably one of the most important pieces of work that we could bring into the community at this time. As we are moving along the pathway for coexisting with COVID, we have learned a lot about collaboration. You know, in our community has always had a hallmark on that, but certainly even more so through this pandemic and the way that we've been able to come together and keep services in place for those people who are counting on us on a daily basis. And I certainly want to give a shout out to our providers who gave up a lot of time and effort in making that happen, as well as the rest of you who are in various other places throughout the community to make sure that we were meeting the needs of people. But the thing we learned was that we can meet them even better. And so that's what today's conversation is about. What are the ways in which we can provide levels of even more collaboration through sharing in the community that will help us do a better job collectively of serving people in our community? So Adamus has adopted the familiar faces concept, and it means different things in different places. There are a variety of communities across the country that are adopting this. Some are adopting it for the title. We used to talk about people as frequent flyers, and probably not the best way to identify those who are grappling on a daily basis with mental illness and substance use. We wanted language that really represented our sensitivity and our caring about the people we serve, as well as our understanding about their needs. So we have adopted a familiar faces concept, and we are looking at the ways in which we're able to really share data, being, of course, aligned with all of our respective laws and policies, and for those in the nonprofit sector, bylaws, all of those things that sometimes constrain us. But as we come together to talk about it, we can find the ways that we can really relax some of our worries, build trust, build relationships, and build a focus on the way that we're better about using information. So what we're going to do to start out today is to ask Rebecca Hall. We have a new NAMI executive director in our community, and NAMI is very engaged in this work on a national basis. So Rebecca, I'm going to ask you if you'll come forward and make a few remarks.
Thank you, Helen. It's been a while since I've stood at a microphone, so this is strange for me. So hi, everybody. I am Rebecca Hall. I'm the new executive director for NAMI Montgomery County, so our local NAMI affiliate. And for those of you who don't know, NAMI is the National Alliance on Mental Illness. And so this work is very important for us as an agency, for us as an organization across the country. As Helen mentioned, really something to provide, more dignity to those living with mental illness and, those people that we see on a regular basis in all of our work. So NAMI's mission is really to provide education, information, support, and advocacy to people living with mental illness and their families. So, this work really aligns with our advocacy around programs nationally, statewide, and locally that will, again, give dignity to people living with mental illness and provide better outcomes. Things like lower incarceration rates, early intervention. Those are all things that NAMI really stands for and is working for in the community. So I'm really excited to be here and to learn more about familiar faces and just to meet all of you. So I'd be happy to talk to anyone more. I'm just looking to meet everyone and really glad to be here. So thanks.
Thank you so much for having me here today. Once again, my name is Stacy Behringer. I'm an assistant professor and in the Department of Psychiatry at Northeast Ohio Medical University. I've done work at the intersection of the mental health and criminal justice system, mainly looking at reentry from jails and prisons for folks with serious mental illness, and also looking at the use of peer support specialists who have incarceration histories. Prior to becoming an academic, I worked in community mental health in Chicago for many, many years. I was part of a project transitioning chronic utilizers of the state hospital system into assertive community treatment services. And I was also part of an initiative to link folks in the Cook County Jail back to services and treatment with mental health. So I am definitely familiar with this familiar faces concept, both as a former clinician and as a current researcher. So what are we talking about when we talk about familiar faces? Some people call them high utilizers or super utilizers of services, or people with complex needs, right? So these are folks who are utilizing a high amount of services and supports through multiple services and programs quite often, and also within a system, right? Or across multiple systems and silos of care. I first became, I would say this idea of high utilizers became more known over the last 10 to 12 years. And I remember reading this article by Atul Gawande in the New Yorker, focusing on hotspotting in healthcare. And this was really where he was talking about the small fraction of people that account for the majority of healthcare costs. And in healthcare, we talk about that mainly due to hospitalizations. And these are folks who have multiple chronic diseases and high social needs. And in the article, Dr. Gawande focused on Camden County, New Jersey, which had started this healthcare coalition looking at how at their high utilizers and providing wraparound services, nurses and case managers who would go out in the community and connect people to services with the goal of preventing repeat hospitalizations. And the story even further talked about a particular case of this gentleman who had a history of homelessness and kidney disease, I believe, and going in and out of the hospital. And through the coalition, they were able to get him connected to housing, get him other supports, and keep him out of the hospital. So they had really good, strong anecdotal proof that what they were doing was working. They had all these great stories of people that they helped. More recently, they did a randomized controlled trial of their intervention. So randomized controlled trial, people are randomized into these wraparound services and people don't get it. And they looked at these high utilizers, their hospitalization rates, like 6 or 12 months after they were entered into this program. And guess what? The RCT showed there were no differences between the folks who were in the wraparound services and folks who just got care as usual. So why would this great initiative that we know is connecting people to services not show any differences between high utilizers who got all of these extra services? And part of that is what we in research called the regression to the mean, right? So people who are high utilizers, not all of them are going to continue to be high utilizers over time. Some of them are going to fall off, right? And so here we have, this isn't looking at the Camden Coalition, but this is in Denver County, Colorado. They looked at their high users across their health system over the course of 2 years. And what we see right here is that over time, the number of high utilizers in their healthcare system is pretty consistent. Over 15,000 people were termed high utilizers, or super utilizers was, I think, the term that they used according to their definition. But when we break down the population, we see there are these sub cohorts. So these are all the people on May 1st, 2011, that were considered super cohorts, and we'll go through broken down. So unfortunately, this orange category are folks who died, who deceased, right? So we're talking about chronic healthcare conditions quite often. So they're no longer super utilizers. But this big blue are people who at the end of 2 years were in that super utilizer category, but are no longer in that status. And then we have this yellow band, and these are folks who were in the original cohort of super utilizers and who came in and out of that status over the course of 2 years. So they sometimes were utilizing high services and sometimes they weren't. And then the small group down here, this pink, are folks who chronically over the course of the 2 years were in super utilizer status. So this maroon or purple color are folks who were not in that status on May 1st, but over the course of 2 years became super utilizer status. So what we see is this is not a static group, right? We have people coming in and out, but I think the folks that we're really interested in, right, are these chronic super utilizers over time and these transitional or episodic ones, these folks in the yellows who are coming in and out, whereas these folks in the blue are what we call transitional folks, right? They transition in, they have an incident or a new diagnosis and they need care, but once they get connected to services, they come out. But then we have these episodic folks who are in and out, and then we have these chronic folks who stay in super utilizer or familiar faces categories. And I just shared this slide. This is from that same study. They broke up the subgroups, and we can see, because this was overall healthcare system, we have all these different groups, but the second highest group with 40% are individuals with serious mental health diagnoses, right? So even when we're just looking within a hospital or healthcare system, our folks with serious mental illness are using those sort of services. So I don't know if you have folks from your healthcare systems as part of your collaboration, but my guess is they might be interested in addressing high utilizers also. So this is just another slide sort of breaking down. And when we look at populations and who uses services, these numbers are fairly consistent. Sometimes these transitional folks, these folks that are in and out of high utilizers of services, usually that's from 80 to 60% of your population. So these are the folks who basically the system's working for them. Something might happen where they need a lot of services, but they get the services they need and they're no longer high utilizers. And then about 10% or more, perhaps, depending on what's going on in your community, we have these episodic high utilizers. So these are the folks who are in and out of services, right? They don't stay a long time, and they're bouncing back and forth between a lot. Sometimes they'll disappear and you won't know where they are, but they always show back up. And then we have these chronic folks who may or may not always be in services, but they're using services at a high level consistently across time. So what does a high utilizer look like? So for me, I thought this heuristic might be helpful in thinking to break down, like, who is our population of high utilizers and how do we approach them. And so for me, being a former clinician, I always think about folks' clinical profiles, right? So we're talking about folks with psychiatric, mental health, substance use disorder, alcohol use disorder diagnoses. It could be an acute, it could be a new diagnosis, it could be chronic. They've had these diagnoses for a long time and are struggling to remit symptoms or stay engaged with treatment. And then there's severity, right? Our folks don't have the same severity of symptoms or vary on which symptoms are more severe for them. And then thinking about the systemic or structural factors. This is my social worker background, right? I'm always thinking about the person and environment. So things like housing or homelessness, their interactions with the criminal legal system. Are they connected with insurance? Is that a gap, why they're not being able to get the help that they need. And then just things generally in our society like poverty and racism and how they impact the impact on people's lives and how they can facilitate connection to services or be barriers to connections to services. And then I always like to think about the social context too. So I know from my clinical background, we would have people who these episodic folks just show up who all of a sudden would be in the hospital repeatedly, and you might find out, oh, a parent just passed away, or a sibling who used to provide sort of care for them and provide that support, and once you can replace that support, they do pretty good again. Or interpersonal conflict, right? For someone who's struggling with a substance use disorder or a psychiatric disorder, if you layer conflict on top of that, that might, exacerbate what is going on with them and push them into this high utilizer mode. So I just wanted to give you an example a little bit more close to the population I think you're thinking of. So this is the FUSE program in Chicago, and this was a jail-based reentry program. So they were looking at folks who were in Cook County Jail, who were also high utilizers of hospital services and had a mental health diagnosis and a history of homelessness. So this was their criteria for this program. And then they looked at everyone that they entered into the program on these specific variables: their current mood status, their history of psychiatric inpatient stays, how often they were booked into the jail, current physical limitations, lifetime homelessness, and recidivism. And based on where people were on these variables, they did what's called a cluster analysis, which is trying to look at typologies, like how do folks hang together on these 6 variables. And they came up with these 4 typologies. And what we see is about a third of them, of these high utilizers, right? So remember, we're talking about a high utilizing population. About 32% of them were average. They weren't remarkable or strayed far from the mean, the average on any of these variables. So I would characterize these folks as probably more those transitional folks, right? They probably, if they got connected to services, hopefully they'll do well. Then they had what they called rapid cycling, and that was once again almost close to a third, which they characterized as younger. They were being younger than the average of these high utilizers. They had lots of discrete homeless episodes, so in and out of homelessness, and they had higher than average felony convictions. And then they had this poor mood category, where folks who were presenting with current poor mood status, also poor physical health, and more serious substance use disorders, symptoms, and drug use, and higher utilizers of detox services. And then they had the lifetime cyclers, who were older, had lots of jail and psychiatric hospitalizations, and prior to this current jail admission had been 6 months or so of street homelessness. So I would, using that heuristic I gave you earlier, call these folks like the more chronic. These are the folks who are going to be high utilizers of systems over time, whereas I think these poor mood and rapid cycling folks are more of that episodic, right? Folks who are sort of in and out. So my reason for showing this is thinking, like, even though you have a definition of familiar faces for your community, that it's really important to also pay attention to potential subgroups within these familiar faces, because you could see our intervention for rapid cycling folks might be very different than our intervention or the services we might want to offer to these poor mood, high substance use disorder folks. So how to approach a familiar faces project? I think you guys being all here together in the room and wanting to talk about this is a great start. But I think the approach really needs to be multifaceted. Once again, thinking about clinical needs, system, structural conditions and social conditions in individuals' lives. As I was saying before with these examples, consider subpopulations. I also think it's great to think about both a systems level and individual level approach, right? Obviously, we want to be addressing individual needs and providing person-centered care, but we also have to think about what needs to change at systems level, right? And that could be anything from doing, coordinated services and co-location to a new policy on something, right? That those can look like very different things. And I also think it's really good, everybody's in the room working together to, once again, focus on short-term solutions, right? What are the needs that we're seeing with folks right now, but also thinking about longer-term solutions, even thinking about, prevention, like how do we prevent folks from getting into this high utilizer category? And that's not a right now thing, but it's a someday thing we want to think about. And then just where to begin, right? So once again, I think each community is going to have their own definition of high utilizers or familiar faces. So it's really important to decide what your definition is. And then think about what is our overall goal with this initiative. Is it just to streamline systems? Is it to provide coordinated care? Is it to provide a person-centered approach to care? Is it merely to reduce costs? Is it to provide care instead of confinement, right? Are we want to keep people in the community and connected to services instead of in jails or hospitals or prisons? And I just want to say something about reducing costs also. So it's like, we're reducing costs for whom? For what part of the system, right? Because by keeping people out of jail, we will reduce costs for the jail, but there'll be higher, hopefully, service utilization costs in the community because people are connected and utilizing services, right? So that's not a zero-sum game. It's more cost shifting, perhaps. And then just other considerations to have is, right, make sure you have the right stakeholders and community members in the room, even people with lived experience who have maybe themselves been touched in many of these systems or their family members. And it's glad to see that NAMI is here and supporting this Familiar Faces initiative. What are the stated goals, the mission, and the undergirding values around this initiative? I know it's hard sometimes to talk about these things, but in my experience with these collaborations, when the stated goal is it's clear and everybody is in support of it, things move forward much more quickly because we all have a clear vision on what we're trying to achieve here. I've heard someone say is once we got everybody rowing in the same direction, things happened much more quickly. So it may seem like it's a waste of time to talk about these things, but I think you save time in the long run. And then leadership. I'm assuming many of you in the room today are leaders in the community across these systems, but we know it's going to take leadership at the ground level. Who's going to be the leaders who are actually going to carry out the work and do it? And do they have the funding and the resources to not only, fund an initiative, but also to fund this collaborative work that's so important. And then finally, I think what was alluded to earlier, data, right? We have a lot of data on one hand, and we have not enough data on another hand, right? What data is important to this mission? Once again, I would say it's data on who is in your familiar faces, breaking that down a little bit, trying to look at subgroups, and hopefully getting to a point where you can engage in data-driven decision-making, right? That's where you're getting information from all the important systems about utilization. And I think that's it. These are my references. I included in here, I didn't highlight it in my talk, but there's a report that came out from Sonoma County, from UC Berkeley, and they did this high utilizers of multiple systems in Sonoma County, and it just might be a good example of something that you guys might do. I am a big believer in borrowing from folks who have done it before, but also being flexible and adaptable to the local context, because taking down things from another community and plopping them in your community may or may not work. You really have to pay attention to the local context. And that is the end of my slides. I will stop sharing. And if there are questions, I'm happy to take them.
Okay. If I can just give you the concept for what we are thinking at this point, and that'll help inform Stacy as well for answering some additional questions about where our thinking is at this level. Stacy, thank you so much, because that overview was really, really important and very helpful. So there are a couple of things that we want to add from the behavioral health system perspective. And it is where are we thinking right now? And so I wanted to make sure the group has that information too, because it will inform questions, I think. The way we're looking at this currently is that, and Stacy said some of the things that I was going to say here, I was jotting down notes. We need a community definition. What is the what in this case? Especially because we're looking at bringing together diverse systems with different levels of engagement and certainly thoughts about what this needs to look like. So one of the first things that we are looking to do is to kind of divide this work out. We're starting with what we're doing here today in terms of identifying the initiative, but our initiative is starting intensely, as well as really trying to gather more information by bringing two prongs together. The first prong is this: the larger group, the umbrella group that would be working together to pull the definition, the information that we're going to need to build out, to bring together stakeholders, because one of the first things we've heard is we need data mapping. There's a whole lot of information out there in our community. We don't know where it is and where all of it is. So bringing together stakeholders who can talk about where the data is, similarly to what we did a few years ago with our sequential intercept mapping process, this would be a process around data. Let's find out where the data is. What are the conditions on the use of that data? And in that part of the process, we'd also be building trust around the data sharing, because that's really important for us to have a real sense of what it is that we need to do. The other thing is with this process is understanding Adamus is not trying to build out a new IT system. That isn't our goal with this. Our goal is, because of the importance of the behavioral health data being utilized, how do we build out something that supports the decisions that we're going to make about how we're going to share data? And who are those stakeholders that need to be at the table in order to help make some of those decisions? We see it, and I'll just say this, we see it more from the standpoint of a data warehouse. So you can pull down data in real time as needed, and have the ability for all of you who have systems in place to be able to link to that process versus asking people to build something new, because who can afford to build something new? And our ultimate hope is that we would have the ability to access or link to the Justice Web system when it is rebuilt. It just makes sense that if the county has this larger system, that we can all be able to link to it as needed, but people can get the levels of information that they need to have. The other piece is really building out, as I said, this two-pronged system. So there'll be a group, the shareholder or the stakeholders group, that will be working on that larger piece of the definitions, where the data is, what the data is, and what our goals are, which are an important element of this. And I have gotten commitments from 3 organizations for part of this process, individuals being a Dayton Police Department, the sheriff has signed on, and we have Joe Spittler sitting back there, who are key components of this stakeholders group, but we need others. It can't be 100 people, but we need to have the interest of others, maybe up to 20, 25 people who could be part of this larger group moving forward. The second part of this is we're going to go ahead and start doing some of this work in order to inform where we're going with this. And so in 2 weeks, the very first case review group will meet because it's important for us to look at the high utilizers. So we have a list of them, and we have them listed in terms of the severity of their particular situations. And so that small group has already been organized for that very first case review, and you all know who you are. They're going to be meeting and talking through the very first of those cases as we're looking at what kind of processes are we going to need, and how can what they're doing, which will start out by helping certainly with more intentional kinds of case review plans and things that people need, treatment plans that people need in the community, and informing the larger core steering committee for what they're learning and what we need to be doing as we're beginning to build out this process. So it's set up deliberately as a two-pronged process to help move us through. Those are the big things. Then I just wanted to make sure everybody knew where we were headed already with some of the thinking around this and bringing other stakeholders into this group. Certainly this doesn't represent the entire system, but we want the system to be part of this. So Stacy, I'll open it up, and Judge has some questions for you.
Thanks. I'm Dave Brandon, probate court judge in Montgomery County. I just had you answered most of it. It sounds like you're going to use Justice Web, or the plan is to use Justice Web as the foundation. And then I suspect Justice Web would pull data in from various stakeholders, whether that be a court or somebody else. I'm curious, I believe that you need the treatment providers involved, and that inevitably would lead to data from the hospitals and other providers. Is that in the works? I mean, and do you have any, I don't know, a screenshot or something where we could see how this interface may work?
I am not part of any data management system. So Ruth Samira and the Coordinating Center of Criminal Justice, I know they have an initiative with Core Data, but that is looking at CIT data, crisis intervention training, is my understanding, but I am not involved in those conversations. In fact, I think they are doing a rollout of that on Monday, and folks who are in that interface, I think, are aware of that. Yes, it would be great to get hospital system data and things of that, but a lot of the healthcare side, the mental health care side, the physical health care side, some of that's HIPAA protected information. And that's part of the challenge in trying to join all these systems together and have access for everyone, is people don't have permissions or rights to see certain healthcare information about individuals. And so there are those legal logistical barriers that what I've heard from counties who have tried doing this is sometimes they're trying to just focus on that, right? Because the ideal, everybody wants to be able to track an individual through and across all these systems, right? That's the ideal. And folks who set their sight on just that as their data management thing run into so many obstacles. And I've heard other communities say that it's demoralizing for the group, right? It seems like an insurmountable barrier, and then their momentum stalls and people get frustrated. So the data is an important piece, but I would say focus on data sharing that you can, and really work towards that. And there are creative ways to think about that. Like I heard of one jail, instead of having the healthcare providers in the jail do their screens, they trained the jail workers to do the screen. And so then it doesn't become protected health information because it's not provided by a healthcare provider. So then that's information that could be shared. Whereas once they get into the healthcare provider system, just the results of like a brief jail mental health screen isn't then shareable with the community. So those are the types of things that you all have to be thinking about, is what information is important to be shared and what information maybe will leave for down the road because there are HIPAA protections and other things like that.
And I your question triggered me because I should have also added, Adamus has a contract with Ascend Innovations and with Gadaha, because they are what we consider our IT team. And they do a lot of our work, our data science work. So that helps us with the hospital data because of the memoranda and all of the other protocols that we put in place with handling that information. So that might be helpful in this process as well.
So if I could ask, from a hospital provider system, our ability to see the other side. So let's flip that and what does that look like?
It depends on what data is available from the jails, right? So I'm not familiar with your county, but my experience is most jail administration data, right, is publicly available. And so that's not protected information. It's just a matter of how you can access that information. And is there a way to get it so you can look at it systematically, right? And so you don't have to go in and look up, every person individually. A lot of jails have public facing data sets, so you know who's in jail at any particular time.
Now's your chance. Ask your questions.
Hi, I just had a quick question. I know you mentioned case reviews and starting some new groups. And to my knowledge, there are some groups that do this exact thing in Dayton. And so just curious how those existing groups will be incorporated in, so we're not, reinventing the wheel, and we're really working with groups that are already kind of working on these issues.
So you may be referencing the MCRT, the roundtable. And absolutely, yes. Kimberly isn't here this morning, but that is part of the planning and conversation that's occurring right now. Blending that work so that it isn't redundant. Rather, it enriches the conversations around the planning for individuals who need services. So that part of it is underway as well.
Hi, my name is Angel Bernard. I'm the social worker at St. Vincent de Paul. I actually manage and facilitate the roundtable. We want to keep that as a frontline workers kind of thing. So where the people that are engaging with these clients, they can actually say, hey, you have an appointment, let's get in the car, let's go kind of thing. We don't want it to become a systematic. So that's why we kind of want to collaborate for this. But that's the definition of the roundtable.
I'll be right back.
So I was just thinking about this, in terms of us having health information exchange, great around Justice Web. And I think like what you said, rebuilding that or building that up, will it be stakeholders that will come together and kind of brainstorm the ideas of what data is, necessary? What do we already have so we can continue to build on that? And is that larger group, or how's that going to manifest itself?
So Stacy may want to weigh in on this as well, but absolutely, yes. That larger group would be the group that is taking the time to do the data mapping process. And Stacy can talk a little bit about what that might look like.
Yeah, so we've heard just some other counties have engaged in this process. And like I said, that's because they tried the other way, right? To try to move towards a seamless sort of integration of data and ran into barriers. And so then their backup plan was like, you know what? We just need to take a step back and figure out where all the data lives, right? Who has what data? And then thinking about once you map that out, then you can figure out what data can be easily shared and how would we do that. Maybe it's creating data dashboards, right? Where you're reporting information in an aggregate sense, right? So that's another way to get around some HIPAA constraints. So you're not tracking an individual, but you might know, how many folks utilize this service, how many are in the jail at any given time, how many are in this program, how, the homeless information system, right? On top of that. So once again, every, agency mostly collects their own sort of data now and have different levels of expertise about how we can slice up our data, how we can create reports and things of that nature. And it's just really important, I think, to understand what's in the community before you start recreating something new.
Mine was a pretty similar question to that, but I guess the one thing I would add on to it is, do we have like an anticipated timeline or almost like a structure of what this is going to look like? Are these going to be like quarterly meetings, monthly meetings? Are there going to be subgroups? I'm just kind of curious if we've done any brainstorming around operationally what this will look like in our community.
So Stacey, you want to talk about what it looks like kind of at the national level, and then, because to be quite honest, the first meeting of the steering committee will determine all that. As we're talking about what we need to collect, what processes we need to begin to put in place, that will help determine what the timeline looks like. If that group is going to be quarterly or less initially, just to be able to get the ball rolling, which may be important. Or if, you're going to want to pull in some of the people who are working on some of these case reviews, and that needs to be a report back on a regular basis. And we have several of our providers here who would be part of that ongoing case review process and be able to help inform the steering committee so it can kind of set its timeline. In fact, I do want Stacey to weigh in, because the one thing that I'm going to say, and I'm saying this because it's something that we have certainly learned from a national level, it doesn't happen overnight. So it is going to take time to build all of this out in a way that has really gotten us to that point of saying, wow, we did this. And we know that, especially knowing that we're going to have to do some Band-Aids of sort with some of the IT pieces as we're moving through this, because there isn't a system out there currently that this can link into. And I know that the county is working on a process, and we don't want to get too far ahead of that process so that we can't link into the portal, because that's just money out the window. We want to be smart about how we're putting the IT into place to support the processes and protocols that we're going to be developing as a team. So Stacey, you can talk about, because you've seen some of that. We don't think it's going to be 20 years. We know we've got a couple of them out there, but we do want to make sure that we're moving with a level of intentionality and success.
Yeah, I just want to, mention when I was working in community mental health in the 1990s, right? We were talking about doing this, and that's when we started this data link project with the county jail and the community mental health center. So, this has been, these thoughts have been around for many, many years. But, we have examples like, I think it's Johnson County in Kansas, who has this great system. And when you talk to them, it's been 20 years in development. I know Summit County is looking at this 5-point system, and I'm not an expert on it. It looks like they're promising that it can do really good things, but some of the pushback I've heard from agencies is then this is another system that you're asking my staff to data input. We already have our own system, right? So it's figuring out what works for all of you in your county, in your community. And that's why I think the data mapping process could be really valuable, because it could save you a lot of time and energy. You might already be collecting the data that would be most useful to this initiative.
Hello, I have a quick question. I can see some of the data being used as on a global level, do you actually envision or have it whether the data that's shared is individual decision-making for judges, for courts, things like that? Understand my question?
I think I do. I think that's an answer for your community to decide, right? So once again, you have to go around can this information be shared, right? So when you're creating this, if you're creating a new database, then it's who has permission to access that data, right? I imagine right now, if you have folks who are in a problem solving, a specialty court, and they're getting services from an agency, you probably have signed releases of information, right? To be able to share that information. So what would change is that would have to be automated in some way, right? That data system would have to know who has permission to see that information from the health clinic. Whereas right now it's sort of in the workers, right? Who negotiate, who has releases of information signed, who has ability to share which information. Did I answer your question?
Stacy, thank you so much for being with us today. So Helen and Stacy, my understanding now is really that Familiar Faces is a model initiative from the National Association of Counties. And this type of model has been piloted successfully in other communities around the country. And for us as a community, one of the challenges that we have is that data mapping process and then that sharing system. So I would love to just hear maybe about one of a community's success stories and how they have successfully navigated this kind of implementation process that we're talking about here in our community, so that we can know a little bit about what to expect and to see that opportunity, definitely knowing that it's not 20 years away for us, but so that we can really see how it's functioning for another community successfully.
Yeah, I think that's a great idea. And once again, I'm not the expert on this initiative. And so I would say, yeah, go and look and see who's done this successfully. Maybe reach out to them and learn from them. Maybe they could come and speak at one of your early organizing things and tell you about potential pitfalls and barriers. And I would look for a county that seems similarly situated to Franklin County, right? Maybe the same size, maybe similar demographics, that kind of things. But once again, I think it comes down to your population, right? Every community's sort of Familiar Faces population might be a little different, and you might need to, tweak things based on your particular population and the resources that you have in your community and the services and supports that you have in your community. But yeah, I'm a big fan of learning from others.
And I can speak to a couple of them because we did have a chance to hear from a couple of other communities. Let's see, Kansas. Kansas has been in place for 20 years now, and their procedures started out initially much like this, with the community coming together. It has now morphed into kind of those community leaders who meet on a monthly basis to keep the work going. But the work has been embedded over this period of time now, so that it's just happening as it needs to for that community. So what we heard from them in a presentation was they still get together, they being the leaders of the organizations who still get together just to recommit or to just spend that time together to keep the collaborative spirit going, which was really, really helpful, because once it happens, there are going to be opportunities for tweaking, for updating, for making it better for the citizens that are being served. So they've continued it. There's an initiative in Kansas, another initiative in Kansas and one in Colorado that are still working through their protocols, because I think one of the things we need to expect is at some point, and I'm going to tell you from the Adams perspective, we are not going to throw HIPAA out there as the barrier, because there's a lot that we can do with data sharing. But in many communities, HIPAA gets thrown out there immediately as the barrier. And that's one of the reasons we wanted to be doing this work with Neomed and with Ruth, Samara, and the team there, because they can help guide us through where those pitfalls are. Yes, there are some spots that it's an absolute no, it's a prohibition. HIPAA tells us where those spots are, but in other cases, it tells us how we can work around it. And I see several of our providers' heads nodding. So we know that we don't have to be the barrier to being able to share data, because it's happening anyway in a lot of ways. Just as Stacy said, there's a lot that goes on informally across our systems. I think we need to formalize it so that we don't have people stepping into those areas that could be problematic over time. So that's an important element of this. I know that as we leave this room, some folks are going to feel a little bit of trepidation. That's human nature. But we would ask you if you would please, if you have that interest in that steering committee, let us know so that we can get meetings set and get rolling. And also, if you have worries or concerns about some of the challenges, please bring those forward as well. Let's address them head on so that we're able to move this in a way that makes sense for our community, because we know who those faces are out there. We know who we are starting with and our own worries about them in the middle of the night. I've got one that I'm always checking with the team about. Did he get out off the curb in front of the bus, right? And I worry about that particular one of our citizens. There are any number of folks whose lives we can make a difference with if we just come together and talk about it. We know that what we've been doing in our silos doesn't work for them. We know that we're really good in Montgomery County at coming together. So we want to make sure that we're doing the best job possible of building out something that is sustainable and just makes sense for the people that we're serving, because they're counting on us. I think that's all we have. If you don't have any more questions, I just want to thank you all again for your time this morning. Thanks for being here. If you'll let them know at the table, if you want to sign on for the steering committee. Also, you can email me, call me, and I'll be glad to answer any questions that I may. This is just the first of many meetings, because we're going to need to be talking about this everywhere we go in order to really get this off the ground. And we'll be happy to come to you if needed. Thank you all so much.